Welcome to The Explainer. Today we're jumping right into a classic clinical question about a set of game-changing drugs in rheumatology, the biologics that have totally changed the way we think about treating autoimmune diseases.
All right, here's the game plan. We'll kick things off with a typical exam question, we'll solve it together, and then really understand the clinical story behind it. After that, we'll break down the common mistakes people make, explore the incredible science that got us here, and wrap it all up with a super high-yield summary to get you ready for any test. First things first, let's put your knowledge to the test. Here's a core question, the kind of thing you'd see on an exam that's designed to check if you know the details that really matter in the clinic. All right, take a good look. This question is digging into the nitty-gritty pharmacology, dosing, and the super important safety rules for some of the most powerful drugs we have. Go ahead, lock in your answer. Got your answer? Okay, let's do the big reveal. We're going to break down exactly why the correct answer is what it is and what makes it such a huge deal in the world of medicine. If you picked A, nice work. You've nailed a really fundamental fact about adalimumab, which, by the way, was a true pioneer, the very first fully human monoclonal antibody to be approved. So, what exactly is adalimumab? Well, it's way more than just a chemical compound. It's a piece of bioengineering. Think of it like a highly specific smart bomb designed for one mission, to hunt down and take out TNF alpha, a major troublemaker that fuels inflammation in rheumatoid arthritis. And why is it being fully human such a big deal? Well, this is where you can see the massive leap in technology. Because it's 100% human, the patient's immune system is way less likely to see it as a foreign invader. This means fewer allergic reactions and, crucially, the drug keeps working better for longer. It's a total game changer. Okay, so that's the science. But how does this all play out in the real world, with a patient sitting in front of you? Let's talk about how these powerful drugs are actually used in the clinic, safely and effectively. Before you even think about writing a prescription for one of these, there's a hard stop. It's a non-negotiable safety checklist. First, you have to be sure the disease is active enough to justify using a big gun like this. And second, you absolutely must screen for tuberculosis. And let me be clear, this is not a suggestion. It's the golden rule. The single biggest fear with anti-TNF therapy is waking up a sleeping giant, a latent TB infection. That's why this screening process is so rigorous and is a standard of care all over the world. Now, this is such a brilliant way to picture what's happening biologically. Imagine a granuloma is like a little cellular prison built by your immune system to wall off TB bacteria. Well, TNF-alpha is the cement holding those prison walls together. When you use an anti-TNF drug, you're basically dissolving the cement and you risk a prison break. You know, understanding why the wrong answers are wrong is sometimes even more important than knowing the right answer. So let's become better test takers and clinicians by tearing apart these other options. Option B. This is a classic exam trap. They're testing you on a tiny but critical detail, the frequency. The standard dose for etanercept is 50 milligrams times once a week, not twice. It seems small, but getting that wrong in the clinic has major consequences for safety and cost. And what about option D? It claims these two drugs are basically the same, just given differently. No way. They are fundamentally different beasts. Infliximab is chimeric, part mouse protein, part human. Adalimumab is all human. That difference is huge, especially when it comes to the risk of the patient's body rejecting the drug. And finally, option E. That word never should set off massive alarm bells in your head during any exam. Absolute terms like always or never are almost always wrong. And in this case, it's the complete opposite of the truth. Far from being avoided, methotrexate is often a biologic's best friend, and using them together is a cornerstone of modern rheumatology. Okay, now for my favorite part. Let's pull back the curtain and look at the amazing science behind all of this. We're talking multiple Nobel Prizes and some really surprising inspiration from the animal kingdom. These drugs didn't just appear out of thin air. They were built on a foundation of decades of brilliant Nobel Prize-winning research. It started back in '84 with the basic idea of how to make a monoclonal antibody, continued with figuring out TNF was the right target, and finally culminated in the 2018 Nobel for the tech that let us make them fully human. It's an incredible story. So in the beginning, the journey started with mice. The problem was, our immune systems are really smart. They would look at these mouse proteins and immediately say, hey, you're not from around here, and launch an attack, making the drugs ineffective and causing reactions. It was a huge roadblock. So scientists needed a new idea. And where did they find it? Of all places, in llamas. It turns out llamas produce these amazing, uniquely small and stable antibodies. They're so cool that they've become the blueprint for developing tiny nanobodies that could be the next wave of therapy.
And if you think llamas are cool, get this. We're now looking to sharks. These ancient predators have antibodies that are so tough and so stable, scientists think they might be the key to creating a biologic you could just swallow like a pill. Can you imagine? That would completely revolutionize treatment.
All right, let's bring it all home. I'm going to boil everything we've talked about down into the absolute must-know high-yield facts that you need to lock in for your exams and, more importantly, for your clinical practice.
So if you're cramming, here's your cheat sheet. Adalimumab is 100% human. Etanercept is dosed weekly. Infliximab is the part mouse one you give through an IV. The #1 rule is you always screen for TB. And remember, methotrexate is a partner, not an enemy. Got it?
And here is a fantastic pro tip for your exams. You don't even have to memorize where these drugs come from, because their names tell you everything. The suffix umab ends like human. The suffix zimab has an X in it, like it's a mix. It's chimeric. And sept is for a fusion receptor protein. It's like a built-in cheat code.
And that leaves us with one final thought. We've gone from mice to llamas to sharks to find better treatments. It really makes you wonder, what other incredible secrets is the natural world hiding right now that could completely change how we treat human disease tomorrow?